will be briefly discussing about tele-assessments and intervention in health. Yeah. So we all know that COVID-19 popularized this mode of intervention and interaction, although it has existed earlier as well. But ever since COVID-19, it has become more accessible and more resorted form of mode of communication, even for mental health interventions. So when we use the term tele, it comprises of any services which are using telecommunication, any mode of telecommunication. And there are broadly two categories, synchronous services and asynchronous services. They are divided on the basis of whether the communication that is happening, is it in real time or not. Like right now, this session that we are having, it is, although it's recorded, but right now we all are present here in the real time, and we can interact through the mode of video, audio, and also written messages. So video conferencing, online chat, online messaging, internet, phone, all of this comprise synchronous services, and email and text messaging are asynchronous. Ethical and legal considerations in tele mental health would be same as it is in in-person psychotherapy. And we have to also like the part of confidentiality here. One more aspect gets included is of privacy, which I will be speaking in further detail later on. And the legislations which are relevant for any client in an in-person setup would be relevant for that client even online. So whether it be Mental Health Care Act or POCSO or Person with Disability Act, all of it will be applicable if the case requires it. Who all can avail these services, the tele mental health services or psychotherapy services? Any client who has pre-registered. So if this was a person who was availing in-person sessions, their intake has been done, but due to any reason, maybe they are relocating or something has come up for the therapist, so they need to shift to the telecommunication mode, they can be the client. Or if it is someone who had approached a helpline, but their situation or their requirement is more than that of just one phone call through helpline, they need a long-term intervention, they can be referred for a tele-psychotherapy, or someone who has been referred by a health professional, like usually in in-person setup. Also, if someone approaches a health setup and they realize that the person may need mental health intervention, they can also be referred. And there can be self-referred clients, someone who themselves feel that they need an online, want to avail an online mode of intervention, they can also be the clients. Some of the factors that needs to be considered before and while we are using this mode of mental health intervention, firstly is client factors. So client factors would involve the person's comfort and feasibility of using the mode. Then is the person cognitively and in terms of their health condition in that stage where they can avail the facility, I mean through online mode. So if it is a person who has a severe mental health condition, severe psychopathology, they cannot be taken in for an online mode. If it is someone who is at the risk of suicide, they cannot be taken up for telemental health service. And In terms of technology and logistic factors, we need to keep in mind um whether the person has a mode of telecommunication, whether a mobile phone and Android phone or internet connectivity, whether it is available to them or not. And will that person have a private space to them wherein no one else is listening to their conversation when they are in the therapy session? If that's not possible, then they cannot be a client for online mode. And lastly, if it's a multidisciplinary team, if the mental health practitioner is part of a multidisciplinary team and this client uh, has been referred or is consulting multiple practitioners, then it is the responsibility, it is to keep in mind that we need to, for the plan of action or the therapy that is planned for the individual, it is to be discussed amongst the team members. The assessment would be similar if it is someone who is, so if it is a pre-registered client whose intake is already over, then this will not be required. But if it is someone who's coming directly online and it's their first time and we are meeting only online, then their detailed intake needs to be done. And the client, it needs to be checked with them whether they are comfortable with an audio mode or a video mode, because there are some clients who do not prefer their video being on. It can be intimidating, like not all of us keep our videos on when we are attending a session, and even when a speaker asks, not all of us keep our video on, so we understand that. So as per the comfort of the client, we will see if they want a video mode or an audio mode. And so if it's an audio mode, it can be directly a phone call as well. Uh, After the intake, the basic information that we take, the socio-demographic details, their chief complaints, the same thing that we do in assessment and which has already been covered in previous sessions. After that, we need to take informed consent for the online mode. The NIMHANS guideline on telepsychotherapy has very detailed informed consent forms for adult individuals, for minors, and also for the guardians of minors. So it wherein we can explain, and it can be an oral consent or a written consent, where we inform and explain the individual what the procedure would be, and what does a psychotherapy is for, because many a times people do not have um, enough awareness and can have wrongly placed expectations from therapy. So explaining that, and once they consent, the consent would also involve discussions around fees, duration of the session, and all of that. Then we can move on to scheduling sessions um, with them, and keeping, like previously mentioned, privacy is important as much as possible as feasible, because if the person or the individual is at home, we cannot always expect them to have a completely private space. But if there are like always someone running into the room where they are sitting, then it will be difficult to continue. This is a very good diagram that the guideline explains, as in when how to go about the whole tele mode of intervention. So first we can announce telepsychotherapy services, that a service is available through text message, audio, or video. And these days we also use social media, Instagram, Facebook, and other modes to do the publicity or to spread the word. And yeah, as I mentioned, the online intake session would, yeah, it would involve verifying the social demographic details of the individual by means of an identity card. So we can ask them to provide a copy of it through email. or WhatsApp. If you have a private WhatsApp number separate for the purpose of interacting with clients, then it can be used. And then the therapist also needs to provide their identity document, uh, so that the person, the individual, the client also knows that we are actually. So this talks about RCI registration number. PSWs don't have that, but we can provide other identity uh, for assurance. And at the level of intake, we need to assess for need for emergency services or referral, whether a psychiatric evaluation or medication is required for the individual. And if that is the case, then the person needs to be referred for an in-person session and service. After the intake, yeah, so the guideline talks about in-person evaluation session, but in certain cases, it's just not possible. With the advent of the use of telemental health, it has reached a point where people living in very different geographical locations also avail these services, because some friend or friend of friend have referred them this therapist. And as it goes, that in health seeking, we all know that we look for a reliable person. And there is often some people may have had bad experience with some therapist in terms of things may not have worked out, but sometimes they have this in mind that the therapist was not good, or that sort of an experience. So people generally go by another person's reference that they know. So in that case, if they are completely in different geographical locations, it won't be possible. But if through the intake we identify that this particular individual is, for them, the telemental health is not suitable, either because of the severity of the condition or they are in need for emergency services, then they cannot be taken up. If we find that the individual is suitable for telepsychotherapy, then only we can continue and go to the informed consent part. And in we can terminate the tele sessions, as it can be on the basis of if the goals have been attained. If when we started and we have we mutually plan the goals, and after the formation, that we have formulation that we come up with, and the mutually agreed upon goals, if they are attained, we can terminate. But it can also be terminated in cases where we realize the person needs emergency service, or there is no improvement, or rather worsening in the individual's condition, or if there is discomfort from either of the side, either from the practitioner or the client, or if we realize that an in-person session is needed. Any client is open and free to discontinue any moment they want to discontinue the services, and without explaining. But if it is the therapist who is discontinuing, then they need to explain the reason. If it is for example, if we have assessed the individual for emergency services, so we need to do this in each session. And especially if it is someone who has had a past history of self-harm, it is a mandate that in each session we assess them for suicide risk or any other risk they have. There can be a person who may be requiring emergency services or psychiatric evaluation or medical management. Then they should be referred, and we should explain them that now we are discontinuing because this mode will not be helpful. And along with that, when we are discontinuing it for any of the above mentioned reasons, we need to also suggest a service to them in their locality. So for this, we need to do extra work and need to have already a list of or at least some mental health service in the nearby area of this individual. It could be discussed. So this can also come up during the discussion with the client, wherein we identify some of the services, whether the individual knows them, or if not, then we should be aware as practitioners. And we also need to keep ourselves updated with local resources apart from health services. If there are any other services that an individual might require, if it is someone, there can be cases of violence that the person is facing, or so in their area or their locality, what are the services that they can avail is something we can refer them before terminating if that is required. um, so in intervention, once the intake is over and we have formulated the plan and the goals are set with the individual, we go about yeah, so each session has to be appointment based, and this can be the structure of session, as I mentioned, can be discussed in the informed consent procedure. When we are taking the consent of the individual, we can mutually decide upon a time, date, and the mode, as I mentioned. And it is better to keep that same timing for each week, and we can also discuss the frequency. It's generally once in a week, but there can be someone who may need it twice a week, and there can be someone who may need it and once in 15 days. So the frequency, whichever is decided, if it's better to keep up with that. um, we need to see that there is a private and quiet space as much as possible for both the practitioner and the client during the intervention. If it is happening, if the sessions are happening on a video mode, then the position of the camera should be such that both the client and the therapist are visible and can see each other, and it's better to keep personal belonging away from the view of camera. We need to be mindful of keeping our phones on silent, keeping uh, using as less applications around the time we are in session, and notifications, so that it does not hinder our attention and concentration during the session. A rescheduling procedure also needs to be discussed in advance. So if the client cancels on the session, how much prior, like how many hours, or what is the duration that they need to inform the client in advance? And similarly for the client, if the client has to cancel the session, how in advance do they need to inform the therapist? And if a rescheduling is required, what will be the procedure? Do we meet next week, or do we meet in the same week some other day, or how that will happen? There also needs to be a discussion around how many minutes or what duration will the therapist wait for the client to join before they leave the session. So a lot of times we see that there are clients who do not join in time. It can be in physical settings also, this happens, and there can be multiple reasons. One of the reasons that we see for a person coming late in session can be because of resistance, but that does not mean that we can, like, we will keep on waiting. And so a lot of people prefer a window of 10 to 15 minutes, but it can be mutually decided and an informed timing for that. And a turnaround time. So the appointment that we fix for the sessions, or any further communication that is required, it can be done through email and or text messages, and there should be a period, like what if the client texts me, when will I be responding, and it should be open. Like it cannot be an expectation from the client that they will contact us and we will respond immediately. um, yes. And for the sessions that are taken, this is uh, recommended format for recording of the session notes. It is better to have, I mean, not better, it is form of a mandate to have our notes, and with the, I mean, it's important that we all have the notes with us. So this can be the format that we use, and it is useful also when we discuss the case with our supervisors, um, even if we are trainee and if we are practicing um, later on after the MPhil. uh, this is helpful. So you can see that the basics of the individual and the method that we are using. So whether it is an individual or a couples therapy, that can be mentioned, objectives of the session, issues or themes that were discussed, and techniques that we used. Then it is very important to also have notes of our observations and reflections of each session. It is very important because it helps in identifying our own biases, or maybe if there are possibilities of counter transference or transference that can be identified if we have notes of our reflection. So in that moment, when we are taking note down and when the client is speaking, if we write it down or scribble somewhere and maybe later make it document it in a proper format, it will be helpful. There are various challenges of using the online mode, and it is, there can be lack of availability of means. So someone who does not have uh, availability of a telecommunication device, it will be difficult. Connectivity, so even if a person has it, and we see that many a times, even for the sessions, it becomes very challenging. There can be a loss of connectivity temporarily, but if it is the fixed time of our sessions and there is a hindrance, it affects the quality of the session. Privacy is, again, it's like one of the biggest challenge. If it is an individual who does not have a private space to them, uh, or it is someone who lives in an environment where uh, the family is the primary source of distress, and if someone um, gets access to the communication that they are having with their therapist, it can further add to the difficulty of the individual. Security in terms of data. So initially we saw that using Zoom was something that people were not very comfortable with. There were discussions around which platform is a safer platform because of the data sharing and unethical practices that are happening online. Um, is something that makes it less secure. And if we have documents of our sessions stored on the computer, then we need to be extra careful about who has the access to the computer and the means. Yeah, so these are some of the references, and thank you.